Myself Dr. JIBRAN Ahmed presents to you Simply Pathology, and today we are back with a very important session. Today we are going to read about juvenile myelomonocytic leukemia. Now it is a very commonly asked long answer question in the exam, and very importantly, there are lots of changes in this particular session in the current WHO 5th edition. So we will discuss about the changes as we go through the lecture. So coming to the definition, JMML, it is a RAS pathway activation driven myeloproliferative neoplasm of early childhood, leading to peripheral granulocytis with monocytosis and frequent organ infiltration. Now remember, previously JMML was under the heading of MDS MPN, but it is now placed, in the current WHO 5th edition, it is placed under the heading of myeloproliferative neoplasm. So let us look at the diagnostic criteria of JMML. So there are three important headings under the diagnostic criteria. So number one, it is the clinical, hematological and laboratory criteria, where all 5 criteria is required. Then there is a genetic criteria where 1 criteria is required, and there are other criteria as well. So we will discuss in details about each one of them. So number one, the clinical, hematological and the lab criteria. Now under this heading, all 5 criteria are required for diagnosis. So let us see what are the important diagnostic criteria under this heading. So peripheral blood monocyte count should be more than equal to 1000 per cubic millimeter. Blast and pro-monocyte percentage should be less than 20% in peripheral blood and bone marrow. Clinical evidence of organ infiltration should be there, most commonly splenomegaly. No Philadelphia chromosome or BCR-ABL fusion gene should be present, and lastly, no KMT2A or MLL1 gene rearrangement should be present in this particular disorder. So over here, if you see that this particular 5th point I have written in red. So anything that I have written in red, it is basically a current change. It is a new criteria which is there under the 5th edition. This particular criteria wasn't there in the 4th edition of the WHO. So this is a new criteria under the WHO 5th edition. So there should not be any KMT2A MLL1 gene rearrangement. Now remember one thing, why they have given like this. Remember that JMML is seen in pediatric patients, especially in less than 2 years of age, and KMT2A gene rearrangement also seen in children. So because there should not be any overlap, that is why they have given this particular requirement that KMT2A rearrangement should not be present. So there are 5 important clinical, hematological lab criteria that we have seen, and for diagnosis all 5 criteria is required. The next important heading is the genetic criteria. So at least 1 criteria is required. So under this there are 2 subheadings. The first is there should be mutation in a component or regulator of RAS pathway. So what are these mutations? Either there should be a somatic mutation in PTPN11 KROS or NROS. So either there should be a somatic mutation over here, or there should be a somatic or germline NF1 mutation, or loss of heterozygosity or compound heterozygosity of NF1 gene, or over here one more is there, or there should be a somatic or germline CBL mutation and loss of heterozygosity of CBL. So out of these 3, any one should be present. Any one should be present. Now for example, if you see that mutations are not present in any of them, then the other subheading under the genetic criteria is presence of non-canonical clonal RAS pathway pathogenic variant, example RRAS2, or fusions causing activation of genes upstream of the RAS pathway like ALK, PDGFRB, ROS1. So either any of these 3 or this should be present. Now very importantly, all these genes that we are seeing, PTPN11, KROS, NROS, CBL, so these are all canonical, and over here the second important subheading that we are seeing, these are all non-canonical. Now actually both these genes, mutations in both the genes, they are causing upregulation of the RAS pathway only, but there is a difference in the GTPase hydrolysis or the GTPase activity. As a result, these are called as non-canonical and these are called as canonical. If you don't understand, it is alright. I just wanted to make you understand the concept of canonical or non-canonical. Just leave it. But remember, both of these classes of mutation are upregulating the RAS pathway. So either of them, either any one of them should be present or this should be present. Okay. Okay. So this is in the under the genetic criteria, one criteria is required. Now there are other criteria. Now when do you have to use the other criteria? So in case, okay, in case it does not meet any genetic criteria, if any genetic criteria is not met, or if genetic testing is not available, for example in developing country like India, for example, then it must meet at least two of the following criteria in addition to the clinical, hematological and lab criteria. Now for example, if genetic criteria, okay, is not met, okay, is not met, or genetic testing is not available, okay, in that situation, in addition to all these 5 criteria, okay, at least 2 of these or any 2 of these criteria should be fulfilled. So increased hemoglobin F for age, myeloid and erythroid precursors present on the peripheral blood smear, thrombocytopenia with hypercellular marrow often showing decreased number of megakaryocytes, dysplastic features may or may not be evident, hypersensitivity, okay, of myeloid progenitors to granulocyte macrophage colony stimulating factor. Now out of all these 4 factors, remember that this is one of the new factors which have been introduced over here. It wasn't there in the previous 4th edition of WHO. Okay, so I will just go through all these diagnostic criteria once more. So for diagnosis, all the 5 criteria of clinical, hematological and laboratory criteria has to be present. Any one of the genetic criteria has to be present, either any one of them or this. Okay, so any one of these genetic criteria should be fulfilled, and remember all these mutations are upregulating the RAS pathway. This one, these group of mutations are canonical, whereas these group of mutations, these are non-canonical. Okay, canonical and non-canonical genes, both of them are upregulating the RAS pathway. The only difference between the rate at which their GTPase activity is there or hydrolysis is there. Okay, now there are certain other criterias also. Other criteria, when does the role of other criteria come? Only when the genetic criteria is not fulfilled. Okay, in that case, any 2 of these other criteria can be fulfilled along with the clinical, hematological and laboratory criteria. Okay, now next we are going to highlight that what are the important changes, okay, in JMML, okay, when you compare WHO 4th edition versus the WHO 5th edition guidelines. Okay, so under the 5th edition, as I have already told you, JMML is regarded as a myeloproliferative neoplasm and it is not under the heading of MD and MPN. Okay. Secondly, there is exclusion of KMT2A rearrangement, as we have already seen. Minor changes, as I have already shown you, that in other criteria certain new criteria have been introduced, so certain minor changes are there. Okay, not only this, if you see this non-canonical part which is given in red, this is again, it wasn't there in the previous edition, but it is there in this current edition. Okay, so this non-canonical RAS mutations have also been introduced over here. So these are the minor changes that we can see, and there is increased stress on the significance of diagnostic molecular studies in this current edition. Okay, so these are the important changes in JMML. Now if you look at the pathogenesis of JMML, remember it is a RAS driven oncogenesis. In more than 90% of the case, there is mutation in either the RAS genes or in the regulators of the RAS pathway. So what are the mutations in the RAS gene? I am going to discuss the most important ones. So the NROS in 15 to 25% of the case, KROS in 15 to 20% of the case. Okay, rarely RROS and RROS2 and RIT1. Okay, so mutation in these genes are present. Okay, mutations in these genes are present. These are the RAS genes. Okay, or mutations can be there in the regulators of the RAS pathway, like PTPN11 mutation present in 35 to 40% of the cases, mutation in NF1 present in 5 to 10% of the cases, mutation in CBL present in 12 to 15% of the cases. Okay, present in 12 to 15% of the cases. Now very importantly, if you see these mutations in these particular genes, that is NROS, KROS, PTPN11, NF1, CBL, these are all canonical. These are all canonical. Okay, whereas mutation in this RRAS and RRAS2, okay, these are basically non-canonical. These are non-canonical. Okay, okay, if you can remember, you remember. If you cannot remember, it is all right. So mutation in either the RAS gene or in the regulators of the RAS pathway will ultimately lead to constitutional activative of RAS pathway. So there is a constitutive activation. That means without the presence of any growth factors, independent of the growth factors, the RAS pathway is basically activated, and basically this causes increased sensitivity of the myeloid progenitors to granulocyte macrophage colony stimulating factor, leading to increased growth and proliferation. Not only this, there can be altered DNA methylation is commonly seen, and it is associated with a more aggressive clinical course. Okay. Now mutations, especially the mutations which are the canonical mutation, as I have already explained which ones are the canonical mutation: NROS, KROS, PTP, N11, NF1, CBL. So all these are canonical mutation. Okay. So these canonical mutations, they can either be somatically acquired, that means they are sporadic, okay, and these are more common, constituting 55 to 65% of the cases, or they can be inherited or in the germ line, ranging from, and these constitute 20 to 30% of all the cases. Okay. If you look at the cytogenetics, they have normal karyotype in 65% of the cases, or in majority of the cases the karyotype is normal. Sole monosomy 7 is seen in 25% of the cases, and most commonly this monosomy 7 is associated with KROS mutated disease. Okay, is associated with the KROS mutated disease. So this is the basic pathogenesis of JMML. Okay. Now coming to the laboratory diagnosis of JML, if you look at the peripheral blood smear, the RBCs, they are normocytic, normochromic, but they can become macrocytic in few cases, especially those associated with monosomy 7. Occasionally NRBCs and teardrop cells can be present. Often there is anemia as well. Coming to the WBC series, there is leukocytosis usually in the range of 25 to 30,000 per cubic millimeter, and it is characterized by the presence of neutrophilia with with very minimal dysplasia, like pseudopelger-Huet anomaly can be there, or abnormal nuclear segmentation can be there. But remember one important thing, that dysplasia is not striking, it is minimal, it is mild dysplasia. Then there is striking monocytosis, more than 1000 cells per cubic millimeter. Granulocytic precursors are present over here. Occasional basophilia, eosinophilia is present. Blast and monocytes are present, but they are less than 2% in the peripheral blood. Okay, blast and blast equivalents like promonocytes, although present, they are less than 2% in the blood, peripheral blood. Now platelets, if you see, they are reduced, so there is a thrombocytopenia. So this is the characteristic peripheral blood smear finding or PBS finding. Coming to the bone marrow, there is a normal or increased cellularity. Okay, erythropoiesis, there can be occasional erythroid hyperplasia, but the characteristic feature over here that you have to see is that there is a myeloid hyperplasia with maturation, and they show no or minimal dysplasia, especially hypogranular cells, myeloid cells, or showing pseudopelger-Huet anomalies. Okay, so there is leukocytosis, or there is myeloid hyperplasia is there. Now limited monocytic infiltration is there, 5 to 10% of the cells they account for the monocytes in the bone marrow, and blasts, including the blast equivalent, that is the promonocytes, are accounting for less than 20%, for less than 20% of all the, so blast is not increased. Okay, and there is no significant dysplasia. Megakaryopoiesis is reduced without significant dysplasia. Okay, megakaryopoiesis is reduced without significant dysplasia. Now other organ infiltration, that is leukemic infiltration, is common in the liver, spleen, lymph node, skin, and in the lungs, and most commonly seen in the spleen. Now clinically, if you see, JMML is a rare disorder with a male predominance. Okay, and the male is to female ratio is 2:1. The median age at diagnosis is 2 years. Okay, usually the patients present with pallor and fever in more than 50% of the cases, dry cough, URTI, upper respiratory tract infection, bleeding, etc. Splenomegaly is present in 90% of the cases, hepatomegaly 80%, lymphadenopathy 50%, and skin rash 30% of the cases. So you are showing that leukemic infiltration is very common in JMML. Okay, and 25% of the cases, as we have already seen, they are presenting in association with germline genetic syndrome. So JMML or JMML like features can be present as a part of a germline genetic syndrome or familial syndrome. Okay, so when they are presenting as a part of a familial syndrome, then the clinical features of that particular syndrome will also be there. For example, if they are present associated with NF1, so those patients are presenting with xanthomas, cafe au lait spots, and some other clinical features of NF1 as well. With Noonan syndrome, if they are presenting along with facial dysmorphism with congenital heart disease. Germline CBL syndrome, okay, so these patients are presenting with autoimmunity, especially vasculitis. Okay, so some inherited syndromes such as NF1, Noonan syndrome, and CBL syndrome predisposed to JMML or JMML like disorders. Now remember one thing I just wanted to make it clear, that whenever GMML is presenting along with the germline, germline syndrome like this germline CBL Noonan, okay, so GMML might not present completely, okay, they might present as a transient disorder, and you have to differentiate these transient disorders which are GMML like but they are not GMML, okay. So that is why you have to recognize this condition. Why? Because such transient GMML like disorders, they have a spontaneous remission. So that is why it is important to recognize these conditions. Now coming to the differential diagnosis in some children with, so the first important differential diagnosis, as I told you, that in some children, not all children, remember, in some children, a few cases associated with Noonan syndrome, they are which is related to germline mutation in the PTP-N11, germline mutation in PTP-N11. In those cases, a transient myeloproliferative disorder can develop which very much mimics like GMML, okay. And remember, in the germline, okay, remember, germline mutations, they impart a weaker gain of function mutation than do somatic PTP-N11 mutation in GML patients, okay. Now that is why, that is the reason for the diagnostic criteria, germline PTP-N11 mutation is not accepted, rather somatic PTP-N11 mutation is accepted. Why? The reason being, those cases which are developing GMML like features, okay, they are having a transient myeloproliferative disorder and therefore they should be recognized, okay, they should not be confused with GMML. I will just 1 minute, okay, I know it is confusing, I will just show you the criteria or the major criteria one. If you look at the major genetic criteria, somatic mutation in PTP-N11, okay, is the diagnostic criteria for GMML, not the germline mutation, okay, because the germline mutation in PTP-N11, okay, germline mutation in PTP-N11, especially in Noonan syndrome, it is giving rise to a transient GMM like condition which is having spontaneous remission, okay. So this transient myeloproliferative disorder which is associated with germline mutation in PTP-11, okay, they have to be differentiated from GMML. Why? Because this transient, as the name suggests, they are having spontaneous remission, okay. And why, as I have already told you, that germline mutation of PTP-N11, okay, they are imparting a weaker gain of function mutation as compared to a somatic PTP-N11 mutation, okay, remember this thing. And somatic PTP-N11 mutation seen in GMML patient. So this is the number one differential diagnosis, that is Noonan syndrome associated transient myeloproliferative disorder. Now the second important differential diagnosis is a RAS associated lymphoproliferative disorder. Now remember, this is closely mimicking those cases of GMML which is having somatically mutated NROS KROS mutation. Again the same thing, if you see over here, in the genetic criteria, somatic mutation again in KROS and NROS, okay, they again can, if there is germline mutation in KROS NROS, they can again mimic some other condition, okay, that is RASopathy associated lymphoproliferative disorder. So what is that? Let us see once. So RAS associated lymphoproliferative disorder, it is a rare intrinsic lymphocyte apoptosis defect associated with somatic gain of function mutation in KROS and NROS that induces a leukopenia with frequent lymphadenopathy and immunological manifestation. So remember, RAS associated lymphoproliferative disorder, it is basically occurring, this is again associated with a somatic gain of function mutation in KROS and NROS, and that is causing leukopenia and not leukocytosis and frequent lymphadenopathy and immunological manifestation, okay. So it is very much like GMML with somatically mutated NROS KROS, okay. But remember, this RAS associated lymphoproliferative disorder undergoes spontaneous regression, okay, and spontaneous remission is there, okay, of all the manifestations. That is why it is important for you to differentiate this RAS associated lymphoproliferative disorder from GMML, because both of them are having somatically mutated KROS NROS gene, okay. So this is very, very important for you to understand. So these are the two important differential diagnoses. Now coming to the prognosis, what are the poor prognosis factors in GMML? Older age, more than 2 years of age, a low platelet count of less than 33,000 per cubic millimeter, increased HbF, overexpression of Link28B. All these are regarded as a poor prognostic factors. Again, acquisition of secondary somatic mutations of SETBP1, ASXL1, EZH2 and other genes are also associated with an adverse outcome. Blast crisis is seen in approximately 30% of the patients. Some patients with germline CBL associated GMML and many patients with Noonan syndrome associated myeloproliferative disorder, they show spontaneous remission. As I have already discussed over here, Noonan syndrome associated transient myeloproliferative disorder as well, okay. So with this, we have completed the theoretical aspect. Now I am going to show you important diagram. So this is the peripheral blood smear, as you can appreciate over here. So very importantly, what we see that there is a moderate leukocytosis over here. So you can see the monocytes over here. Okay, you can see the lymphocytes, you can see the neutrophils, you can see certain granulocyte precursors, and very importantly certain NRBCs can be appreciated. One striking feature, if you see, there are very less amount of platelets over here. So there is thrombocytopenia, as we can appreciate over here. Okay, there is thrombocytopenia over here. Okay, now coming to the bone marrow aspiration, if you see, it is hypercellular. You can see the bone marrow, it is hypercellular, showing metamyelo as well as myelomonocytic hyperplasia is very frequent. You can see the monocytic cells over here. Okay, you can see the monocytic cells, especially you can recognize the monocytic cells by the characteristic cytoplasm. Okay, by the characteristic cytoplasmic feature. Okay, so there is myelomonocytic hyperplasia over here. Okay, so with this we have completed the discussion of juvenile myelomonocytic leukemia. Thank you very much for watching this particular video.